Hi, last lecture for Module 6. It's a relatively short one, so let's go ahead and look at the Micturition reflex. Micturition is urination. So it's a spinal reflex, and it's pretty straightforward. It's kind of interesting. Thought you ought to sort of appreciate how it works. In this slide, the bladder is shown relaxed and filling. So remember that it's not drawn here, but there are a couple of ureters that are coming in from the kidneys. So those are the ureters that are filling the bladder. And as it fills, this reflex is integrated in the central nervous system. So here is the spinal cord. So this is our CNS. So this nerve, or this reflex, is integrated at the spinal cord level, not in the brain, but still the CNS. And what happens while it's filling, well, there are two sphincters that are involved. The first one is smooth muscle, and it's an internal sphincter. And it's smooth muscle. And it stays sort of passively contracted, so you don't have to think about it. That smooth muscle is great for that. It can stay contracted for long periods of time. And the external sphincter is also contracted, and this is done through tonic discharge, tonic stimulation. So tonic just means that it's constant. So let's say constant low level. But there are action potentials that are traveling along it at a regular rate. So it's constantly firing tonically, and that causes the skeletal muscle to remain contracted. So it's a skeletal muscle, nicotinic onto ACH receptors, story that we've looked at before. And so it just fills, and both of those sphincters stay closed. And again, don't forget that there are higher brain centers that can influence this. So that's filling. Next slide is micturition, which is the voiding of the bladder, the urination. So start with the bladder being full and stretch receptors now fire. Similar to other stretch receptors, similar to the stretch receptors that we had in the carotid and aortic bodies for baroreceptors. They start to fire as they become stretched. They send action potentials to the integration center, to our CNS again, and it branches, and a couple of red interneurons, and at this synapse, when this neuron fires, it inhibits the motor neuron. So in this case, the motor neuron stops firing, so the discharge is inhibited. So the skeletal muscle relaxes, and the internal sphincter relaxes also, and at the same time, there are parasympathetic fibers that at this synapse were stimulated, and those fibers then become active, sending action potentials to the smooth muscle, and the bladder contracts. So, to recap and summarize, once the bladder is full, stretch receptors fire, and in the CNS, that activity, the firing of the sensory neurons, inhibits the skeletal or the somatic motor neuron to the external sphincter. Remember, this is skeletal muscle. So it relaxes. And at the same time, the parasympathetic causes the contraction of the bladder. And again, you have higher brain centers that may get involved. So even though the bladder is stretched and the sensory neurons are active in stimulating this pathway, you still have the ability, to hold it till an appropriate time. Assuming that the musculature is still intact, and that's one of the reasons for, as people get older, it's important to practice those Kegel exercises to keep that abdominal pelvic floor, the muscle tone, intact to avoid incontinence. So that's the basic Micturition reflex. And the next two slides are just a few notes on diuretics, and then we're done. So, things that act as common diuretics. Caffeine is one, and it's thought that caffeine, the way that it works, is to inhibit sodium reabsorption in the PCT. So if you inhibit sodium reabsorption, water follows, and water follows the sodium on out to the bladder. And caffeine also increases GFR by vasodilating the afferent arteriole. And that would cause increased blood flow into the glomerulus, which would increase the GFR. So caffeine, inhibiting sodium reabsorption and increasing GFR. Alcohol, remember that alcohol is a central nervous system depressant. If you remember nothing else about alcohol, remember that it's a depressant. And since you inhibit the CNS, you inhibit the release of ADH. And if you have less ADH, you have less of an antidiuretic effect, so you have more of a diuretic effect and increased urination. Loop diuretics. Let's put a couple of stars on loop diuretics. And they work on the ascending limb of the loop of Henle. And you remember what's going on in the ascending limb of the loop. It's the sodium, the potassium, and the 2-chloride, and that becomes inhibited. So loop diuretics inhibit that transport. So what happens is that those ions stay in the filtrate and water follows. They're very effective diuretics. They're sometimes known as a water pill. I would like you to remember one brand name, and that is furosemide is the generic, and Lasix is the brand name. And those are very common antidiuretics. They're often given to people with high blood pressure because they're very effective at dropping water. The big caution, the big thing that you need to remember, though, about a loop diuretic is that you're also going to be losing that potassium. Who cares about the sodium? We have more than sodium than we can deal with. But the potassium is very little in the blood and in the ECF, and so if you lose a little bit of it, that can be significant. And that so a small change in the volume in the ECF can have significant effects on the body. And it all gets back to that hyperpolarization and depolarization of the RMP with hypo and hyperkalemia. So, if a patient is on a loop diuretic, they are typically also on a potassium supplement. But one thing that you want to be watching for if a patient is on a loop diuretic is to watch for hypokalemia. Because you're losing it. You're not reabsorbing it. And the last slide, not really diuretics, but it's about diuresis, urination. So a couple of things to think about. Osmodiuresis or diabetic diuresis. How does osmodiuresis work? Well, it just means that there are more solutes. So for example, with diabetic diuresis, if we're talking about diabetes mellitus, you know that there's an excess amount of sugar in the blood, and we just looked at the transport maximum. So maybe I'll put a little note here to remember the TM story. So that means that it's excreted, the excess, it spills into the urine, and then water follows solutes. So what are the classic symptoms of uncontrolled diabetes? Increased urination through this process and increased thirst. Why the thirst? Why are people thirsty? They're incredibly thirsty if it's uncontrolled. Well, their blood now is hypo or hyperosmotic. So, too many solutes for the blood. The brain detects the hyperosmolarity of the blood. And how do you deal with that? If you can't get rid of the solutes, try to dilute them out by drinking water. When you get dehydrated, your blood becomes hyperosmotic. You're losing water, solutes are more concentrated. Cold diuresis. This is the phenomenon that every time you go swimming or if you get cold for any prolonged period of time, you generally need to urinate more. Well, what happens is that when you get cold, the body is conserving heat. So it moves it away from the shell or the skin, if you will, and shunts the blood to the core to conserve heat. And as that blood shifts from the skin to the core, the blood pressure in the core goes up. As the volume basically increases, the heart and brain detect increased blood volume in the core, and they release ANP. The atria are now stretched more than they were before. You know how ANP works. And it affects ADH also. So ADH is, okay. So that's it. And if you have questions, please get a hold of me. And we have one more module, module 7, which is on fluid and electrolyte balance of the kidneys, and then we'll have another exam in a week or so. So, till then, study hard.